Well, welcome to our session on oral health, and we're excited to see so many people interested in this topic today. We certainly know that the oral health of many of our patients has been affected during the pandemic, and you all know that oral health directly leads to physical health. So I'm going to ask our panelists to introduce themselves to you today, and then we'll engage in some discussion with them. So we do have Dr. William Carroll on Zoom with us. Introduce yourself and we'll make sure we can hear you.
Yeah, my name is Dr. William Carroll. I'm the academic dean up at Roseman University. I've been here about 10 years, and I brought my bride from Hawaii here, and it snowed. And she and I just put that out there because when you come from Hawaii and there's something, we only see snow as shaved ice. But we've really enjoyed our time here. My background, I did 30 years in the military, the Navy. I went to the University of California, San Francisco, and I did a residency program at Walter Reed. Now, when I was there, it was the Naval Medical School or Dental School. And I've run a couple of actually 2 residency programs, postgrads, so which I think actually was an advantage for what I do as a academic dean here. The postgrad programs, especially hospital, are very focused on person-centered care, the role of epidemiologists and disease, not just in the mouth, but also outside the mouth. And I think the perspective, especially in healthcare education. So, but I do have connections to Utah. And some of you probably know where Helper is. And I'll bet a lot of you don't know why the name is Helper, but Helper and Price, the Wyckoff family, which I'm related to, they had a name on a building downtown Salt Lake, and it's gone now with the new high rise. But so I have relatives from that area of Utah. So I'm very actually quite familiar with rural Utah. Price and Helper are especially about as rural as you can get. So that resonates with me and the stories I heard from my father about the challenges back in the Depression and beyond, driving trucks. And I quite a affinity for Utah and commitment to making a difference here in the state. So,
well, thank you for joining us today, Brendan.
Yeah, no, it's my pleasure. I wish I was down there. I wish I wasn't stuck up here.
Yeah, and our lovely fall weather, right? It's pretty good young today. I'm Brenda Armstrong. I'm an associate professor here at Utah State University, and I serve currently as the department chair for the Department of Dental. And here in this area, we serve as we have 2 roles. Our first role, of course, is to educate students to become dental professionals, dental hygienists, particularly. Our other role that we see in our mission is to serve community members. So we serve as a safety net clinic for prevention, specifically dental hygiene services here in this area. And this topic that we're going to talk about today is important to us because most of our patients experience barriers to care. That's why they come to us, as part of costs. But we also see that those barriers to care filter into other areas of medical care, and of course, their oral health is influencing their overall health. And we see patients with many comorbidities that continue to cause problems with their oral. Glad you're with us today. Dr. Howard.
I'm Dr. Howard, and I work at Family Health Care. Most of the time I'm up in Cedar City, but on Fridays I'm in St. George Clinic thing out there. I grew up here, Southern Utah and Hurricanes specifically. Went to Dixie and SUU, kind of both back and forth. I got my bachelor's from SUU, and then of course down here. And I went to dental school at the University of Oklahoma City. And since then, since we graduated, we moved back here, back close to family, and working at Family Health Care now. So
Ryan came through our program at Dixie and SU. We're just tickled to have him back here. We're good at QHC. It's fun to have him here today. Well, let's dive right into this. How has the pandemic affected oral health? Who wants to jump in? Go for it, Brenda.
I'll talk.
brought some notes, because I wanted to make sure that I thought about clearly about the things that I wanted to share with you today. It's been interesting for us. Of course, the pandemic influenced how we delivered education to our students, but that also filtered into how we delivered care for the patients that we see. But some of the things that we have seen as it relates to the patients that are coming to us is that there was a little bit of a disparity between patients who had health literacy and those who don't have good health literacy. And those who had good health literacy, knew how to educate themselves, were more apt to come into our clinic than those who don't have good health literacy. And that those barriers even became more exaggerated during the pandemic. And so now that we're seeing patients, we're seeing more infection than what we've seen in the past, because also people waited to go to the dentist. If you remember, we were shut down, dentistry, from March until early June. For us, our clinic didn't open up again until August. Along with that, we were not denied, but asked not to come to long-term care facilities. We have a mobile clinic that we're able to get out into the community and take care to where the patients are either living, who can't come to us, or who are receiving other social services. So we go to long-term care, we go to early Head Start, we go to workforce services with our mobile clinic. And long-term care was saying you can't come. And even this August of 2021, some long-term care facilities were allowing us to come, and others were still being very cautious and not coming. So we've seen people waiting for oral health care, either for different reasons and the barriers that they already experienced too. How about you, Dr. Howard?
Yeah, it's been, especially when the pandemic first broke out, because no one really knew what was going on. They limited us to just emergency treatment, like if you're in pain, do something. But besides that, we'll kind of wait and see what's going on here. And kind of what we saw happen, especially even people who were in pain, a lot of them didn't come in. We kind of found out later on. And then the people that we kind of postponed because they weren't hurting, a lot of people you had, things that were bigger but weren't starting to give them issues, and then they kind of start getting worse by the time we could finally get them in. So it was interesting because it went from didn't hardly see anybody because nobody would come out to finally when things started coming down, just a kind of a bombard of people coming in because you had so many issues that hadn't been taken care of that it became, and we're still kind of trying to catch up. It's been kind of hectic trying to get everybody in. It's about 2 to 3 months in most places to get in. So.
Dr. Carroll, what are your thoughts?
Well, I have a perspective that's similar and also unique. We had 100 or almost 100 students in a class, 84 actually at that point. And fortunately, the pandemic hit after most of them had completed their clinical requirements. So that class of 2020 actually graduated on time, and all of them. And we're very lucky. So timing was great. But at the same time, Friday, March 13th, I'll never forget, we were told that we couldn't have in-person classrooms. And so we converted to Zoom over a weekend. And what I'm doing right now became the norm in our program for a lot of other programs. So we were able to get the didactic online, and the didactic classes actually carried on. We never missed a beat on that. It was just, people were at home and getting used to cats and dogs and birds and children coming in. But that was actually, it was kind of nice. There was normalcy associated with that. The clinic for education, that was a challenge because we're under Salt Lake County. And I was talking to Vicki Drent, who's our director of clinic ops. A lot of you probably know Vicki, and I've known her a long time as well. She used to work with us in the Navy, and when she was at Ultradent. But anyway, the challenge was we used to do just in time. Now it became just in case for supplies, logistics, and getting those logistics pipelines started up. We didn't really shut down completely. Part of what we do is serve the area, especially the need, those that need care. So we had to kind of a limited emergency clinic. But the ramp up was tough. You know, as you guys both have said, both Brenda and Ryan have said, it's a lot of people a little nervous at first, not sure we were open. And so that was a challenge. But we, the boss, the dean, LeCarey instituted a voucher program, which helped. And we enlisted the aid of a couple of Hispanic radio stations in the area to get people to come in. And but this, you know, for us, like all of you, it's the COVID protocols. That was the big challenge for us, Lorraine Healthcare, and then also the COVID protocols for the classroom as well. So it was two-pronged. And but it's, you know, ultimately we have graduated in class 2021 graduated as well, and on time. So, but I tell you, for us, it was a team effort. We had everybody doing this. It was we couldn't have done this if it hadn't been a group of us just working together, trying to figure out how to make this work. So that was our approach. So challenging, we learned a lot. I learned that Zoom could be tough on the back. And it's important to get up and stand once in a while. I found out that a card chair and a card table are not a great desk for Zoom calls. So learned a lot.
You touched on a lot of the adaptations that our patients are making, but how about you as dental professionals? How did this affect your lives? How did it affect your practice? And what do you see moving forward?
Yeah.
Let me go. If you remember, I don't know if you remember, we didn't know how COVID was being transferred, right? We thought it was probably transmitted, it's probably aerosols. And so there came out a study early on, probably May of 2020, that said dentists and dental hygienists were the occupation at most risk. Mm-hmm. And so then we were all left scratching our heads, like, what are we going to do about this? And some schools went as far as throwing up, I don't know what Roseman did, but putting in plexiglass in between every operatory and special zippered walls, so you could go in there and try and have a contained space. We were all looking at air filters and increasing PPE. An example of PPE, I'm sure the dentist was way higher than we were, but we spent $23,000 last year on disposable surgical gowns because we just, I'm sure you guys were 3 times that.
Well, we spent a lot, and it was the logistics of getting it. The just-in-time went away. So
yeah, you had to order gloves. So, 1 month gloves were shortage. Next month it was mask shortage. Next month it was surgical gowns. It was constantly trying to work with our vendors and get enough supplies to keep us moving. Not only the education, but also seeing people. What's interesting about that is, so we all did certain things, right? We increased our PPE. We figured out how we were going to control the aerosols, and then how we were going to clean the air and keep everybody safe. And after we did all those things, well, let me add, dentistry knows how to handle infection. We had a scare in 1980 that related to the HIV virus, where we had to fix things then. The one thing we didn't do in the 80s was what we had to do now, that had to do with aerosols, because the 80s was about a bloodborne pathogen. Now we're worried about aerosols. And so we had to think that through. So dentistry was on their way. We just had to address the aerosols. And that's what we found that we were doing. What's interesting, though, is that in July of this year, a study came out from Ohio State. And they looked at the aerosols that are generated in a room related to ultrasonic cleaning. Think about when the hygienist has the ultrasonic in your mouth. Implants, placing implants, or doing some restorative procedures like a crown or a filling. And what kind of aerosols, and they measured the aerosols in the air before the procedure, during the procedure, after the procedure, and compared that to what was in the oral cavity and what was the microbiota that was in the irrigant line, so the water, whether it was tap water that we're pulling from, or whether we're filling our own tank. The aerosol, the microbes that they found in the aerosols in the air was from the irrigant water, not from the oil canister. As long as they were using that high volume suction, not the little straw, but the stronger suction when someone's doing a filling, then they were able to control the aerosols. And so we were doing good things all along, as long as you were using that standard HDE. Now that's one step, we need more steps, right? But as long as it was being controlled intraorally, those saliva microbes were not in the aerosols. Isn't that great? Great
That's
news.
good to know.
So the other thing we learned was that PPE works.
Yeah, that's
PPE works.
That was probably the biggest change is the PPE that because we always wore PPE, but then it went kind of overdrive, like the whole gown, we had the mask, the N95, which is quite a bit, more stifling to work with after
Face shields.
face shields, we had the face shields and everything like that. And then we made sure with our patients that we took the temperatures, because, it's kind of so big at first, no one really knew what were the symptoms, because it seemed like every day was coming up new with different symptoms. But that's kind of was the standard where you take the temperature, if it had, any side effects of anything, we would hold them off if possible. So it was healthy. So.
Dr. Carroll, did you have something?
Yeah, we did the same thing, and she's right. I happened to be in San Francisco in 1988 at UCSF when HIV hit, and the dental school changed dramatically after that first patient was identified, and wearing gowns and gloves. And I never thought I could do dentistry wearing gloves, because we used to not wear gloves back then. It was a paradigm shift, and I told people, I said, when we went through that very similar experience, you have to rethink things. Well, the interesting thing about the data too is there's been a edict from, I believe, CDC or OSHA since 2007 about, people that are sick and have an upper respiratory infection are supposed to notify, or somebody should ask. Ironic, it's been around that long. But we did the temperature like Ryan said. We set up a lot of plexiglass, like you said, Brenda, same thing. Massive. That was another thing, finding plexiglass. Everybody was looking for it. And I remember somebody screaming when all of a sudden we had the plexiglass here, because it was quite the challenge to get it, to put it up, to make sure. And we had pathways. We didn't have a patient would come in, and unless that person was absolutely necessary, a guest to assist them, we wouldn't allow them in. We had to be very careful. We spread out the operatories, so they were every other operatory in plexiglass. And it was, a team of people kind of evaluating a one-way path in, a one-way path out. We revised a lot of protocols that we used in the clinic. Again, the training was huge. When you got a complex like this with several hundred people in it, PPE standard precautions, including the bloodborne pathogen standard. We went over and over with it. We've done it before, and as you said, we are well prepared. We have defined that over the years. And but as we all know, we were also anxious about the CDC. I think it was like watching an NFL game to see when the next touchdown would come, who was going to change, what was going to change. It was, okay, now this week, what do we do? What's excluded, what's not. But we did, I think it sounds like exactly what you did, Brenna, and Brian, exactly the same thing you did, just on a much larger scale. But the patients would come in, we take their temp, they were in an isolated area, masked, they followed a pathway up to the clinics and then a pathway out. So we were trying to avoid people passing each other. We did that for several months, it worked. The problem for us was we had all these students who needed, to see patients. So we had this split schedule overlapping to allow our students to come in, especially our D3s and 4s, to see patients so they can meet their clinical requirements. And that was the big challenge in making sure that worked. It did, actually it did, but it took a lot of creation. We threw all the rules out in terms of, we knew the disease was there, didn't know, as you said, Ryan, you didn't know, somebody coughed, did you just give it to everybody? The big unknown. And, it was a constant challenge each day. A lot of us were on edge. You want everything to go right. You're always worried about, will we be the next COVID epicenter, especially with all the patients coming from different areas and trying to screen them as carefully as possible, still with the unknown that they may not know they have it. We don't know they have it. There wasn't a vaccine yet. But, and then of course, the biggest was just making sure we had enough supplies. Vicky's office turned into our supply room. Everything, anytime she could get something, it came in and she stacked it in there. So we had the supplies just in case we didn't. So, no, it was, it reminded me a lot, Brenda, of 1980 in San Francisco up on the hill at Parnassus Heights. It did that. It was deja vu, Groundhog Day all over again. Absolutely.
I'm curious with these advances, what is going to stay as a part of your normal protocols, and what do you think is going to go away?
That's what I've noticed is putting that on, like the face shield. Like at first it was annoying because it's hard to see through it, you know, and do your work. But then at the end of the day, I noticed how much gunk was on the face shield, and I was like,
Yeah.
You're glad you were wearing it.
now I still wear it. So one of those things that.
Yeah. Well, it's like gloves. I fought that. I was mad because they said you have to wear gloves, but now I would never think about not seeing a patient without gloves. And the same thing with the mask. I mean, you get used to it after a while. It just takes time. And I can remember our endodontist in school and complain about they couldn't feel the, to fill the tooth or do whatever, file it out. And now, of course, nobody ever says that. But yeah, it's just an adaptation. And but Brenda's right. We led the way. We've always done that, and it's always been there. I think it's just reinforcement of what we already knew was working. And I think that is a message, or a powerful message, that will carry on, that these protocols work, they really do.
I would add that, so we never did the plexiglass. Our patients were more than 10 feet apart from each other, so and we did have some air purifiers put in the area. What was interesting, after a year of that, we went back and kind of reflected what happened. We never had any evidence of the transmission of virus.
Same here.
We felt like PPE works and infection control procedures work. And we just continue doing things. But we did learn a few things, like, hey, you know what, maybe I do like the face shield because I'm seeing what's actually landing on me.
Yeah.
Like, we're starting to wear surgical caps, because if that's landing here and I go home at the end of the day and I sleep on my pillow, what's in my hair? So we're still wearing surgical caps. So there's some things we learned, but I go back to that study I shared to you from Ohio State. The microbes that are in the air are from the water lines. They're not even from the oral cavity, as long as they were using a high volume suction. And so I think we've learned some things along the way. We just didn't know in the beginning. And that, so I'm going to guess a lot of your plexiglass has come down.
It has. And speaking of that, we do flush those water lines for 2 minutes. Remember, at the beginning of the day and 20 seconds in between patients.
Yes.
So that's the CDC guideline for everybody who hasn't heard that one before. How's that? That's the one thing I bet we all could. I know it sounds like Brenda, Ryan, you both could recite that blindfolded without much prompting. But yeah, no, we took it all down. And actually, you're right. We haven't had an instance. But again, it goes to washing your hands, following standard precautions. They work as long as everybody's on board with it. So it was a reaffirmation that our system was working. It's just, we had to step it up a little bit with the face shields, just like we did in 1980 in San Francisco. So
we have an audience member here that I recognize.
Yeah.
And we worked together at the Veterans Home here in Southern Utah. And I'm curious, did you see a lot of dental issues at the time when we could get into the Veterans Home?
Yeah, we saw more dental issues for several reasons. One was staffing issues. Staff and leave. Of course, now the mandates, we're seeing us coming up. One thing we saw when we went about 15 months without a lot of visitors, family didn't come in and everything to see their loved ones. When they did get in, they noticed
dental problems. They really did harp on the hygiene more and things. And so we changed procedures that have to be with that. So
Good.
those were probably the main things I saw. Of course, so when we get the hygienist back in there, when they coming out, they're all lined up, ready to see them.
Yeah.
So you alluded to, from the patient perspective, we know that patients have struggled with their willingness to come back to get their checkups and things like that. How is that going to be resolved? And where do you see the future of that? How are you encouraging patients to come in? And Dr. Carroll, you've got a whole dental school, lots of dental students to find patients for.
Well,
Well, yeah, you know, I think once people got the word of mouth, I noticed in our neighborhood, we have a huge population, obviously it's growing. And we had, I don't know, it's hard for me to hear, but we've actually, we've got lots of patients. We don't have any trouble right now, but getting people, there was a lot of pent up need. But then once the word got out, and we're back up to speed. For us also with the outreach clinics, because a lot of what we do in dental education is we want the students out in the community, in the rural areas, in the city levels, working with the very diverse populations. They need to see that. That's part of our mission, is to train them in the different, socioeconomic strata of this country, and why it's not everybody has a regular dental exam or feels they can plug into the primary healthcare system, which I label dentistry as part of primary healthcare. And so that for us has always been a challenge. Those clinics rotations are difficult for us right now because we're dependent on these other clinics to allow our students to come in. That just started opening up though, and it's been I tell you what, right now we're pretty doggone busy down there. There are lots of patients. We're up to speed. We settled into a routine. People got used to wearing the. Matter of fact, I had a student come up here and she said to me she really likes wearing the spacesuit, and I thought that was, I like that. It's good to hear a student engage, because I know if one's coming up to tell me that, the others are telling them. So, but it's just, I'm glad we're back in person, quite frankly, for our classroom activities, because we really missed that. There's a big, for us having our students in Minnesota, no offense, Brenda, but they're all over the place, and not having them in the classroom with us so they can, we can, talk to each other and work in teams has been one of the biggest challenges, but we're back doing that now, and it's better for everybody. So I don't know if I answered the question. It's just a lot of things on my mind.
Yeah. One of my concerns for the patients is the patient who can't pay for dental care.
Yeah.
And so now we have this increased PPE expense because we're doing more.
Yeah.
And increased infection and barriers and all things that we're doing. A lot of that is costing us more money. So where does that transfer to the patient? At the same time, the patient is experiencing, a lot of these low income patients have had a decreased income during the pandemic. But then we're now in this 6% inflation rate right now. What is that going to do for these patients who can't pay? And I think these safety nets are going to become really important, like family health care or getting preventive. In our clinic, there's not a lot here in St. George that serve as a safety net for a patient. And it's you, and it's us, and it's the doctor's volunteer clinic, and that's about it. And so I worry about the low income patients. They already have barriers. I think there's going to be barriers added because of what the economy is doing right now, and the low wages and the high rent and everything else is adding into it. Those are some of my concerns.
Dr. Harold, maybe you can share a little bit for those who aren't familiar with the services that are offered at some of the FQHCs that you've done services.
Yeah, so family health care, we offer a sliding scale. So kind of based on income, we can put you on a certain slide. And so, which is super helpful because on the lowest scale, we're like a third of the prices are less than your general practices you find around town. So, but even with that, I mean, we see that every day, even with these lower prices, people say, I like to get it root canal to save a tooth on the tooth aid, they don't have the means to, save a tooth, so we end up having to pull it. Unfortunately, we do have certain grants that we can't use in certain cases, which we try to use as much as we can for some patients that, can't afford to do it, especially when they're young and they have a tooth, they have to pull it out. And so it's always a struggle.
We have a grant also that allows us to hit a certain poverty level. We can see that's been helpful. But not everyone falls in that area, and just because you're not a certain poverty level doesn't mean that you're struggling. Right?
We know these services exist in the more urbanized part of the Salt Lake area and in St. George, but what about our rural communities? What's there to serve people?
We do get a lot of people driving from hours away to come to our clinic.
Yeah. We actually do too. We do see a lot of patients that actually drive in from rural areas. It always surprises when I realize that we have patients that are more than 50 some odd miles away. And we also have a patient assistance fund the students help with, fundraiser. And we have a special dental plan that's basically sliding scales, waive certain fees to help people, because we recognize that a lot of folks lost their main source of income. And with inflation, as you said, Brendan, now 6% or more, it's starting to eat into their budgets. So, and we've re-upped our Give Kids a Smile campaign and back to school brush up events. We can't provide as many slots for those because we 400 to 500. We just don't have, with the COVID protocols, we have to be careful. So, but this year, Dr. Moffitt, who's our head of that now, he's a pediatric dentist we have up here, and they had at least 200 a couple of weeks ago, and we'll probably do it again shortly. So we're trying, we're trying to and getting the word out that we're here. I do remember when we first started the school, we worked with the transit system to bring a bus line here, and they sent a little bus, and it had paper signs literally in front of the school that was a bus stop. Of course, the first time it rained, you couldn't even tell what it was. But now over the time, people did find us, even though we're in for those who don't know, we're actually in a very nice residential area in Salt Lake. But we do have Front Runner and we do have Tracks, and people found us, and they're still finding us. But that is a challenge. I worry about that too, Brandon, about those families that are struggling. That is a concern. So.
Yeah. Thank you very much for providing affordable care, both while promoting education and taking a hit to your own personal budget by serving the community once a week. But I wonder, do we have any idea about the unmet need for oral care, especially among the socioeconomically disadvantaged citizens of Utah? Is there any data out there that you folks know of?
I can share two sources. I don't know what.
No, I just know that I know a lot about the demographic, the makeup, who the healthcare providers are in the state, but I do know that I haven't seen anything recent. Brendan, go for it.
Well, so there was a study. I told you I took notes.
There's academics.
Yeah, there you go.
So Michelle Martin, her name's now Baxter. She served as an oral health program specialist for the Utah Department. And they did a retrospective study a couple of years ago. They looked at how many people were going to the emergency department for non-traumatic oral care. And they did it retrospectively. So the years that they looked at were 2007 to 2017. So they had 11 years of data. And what they found in Utah in those 11 years is that $52 million was spent in the emergency department for dental needs. 55,000, over 55,000 visits during this 11-year period, and 48% occurred after business hours. And the average cost to the visit was around $1,500 for the state. So what was the patient getting for the $1,500? basically a prescription for an antibiotic, maybe something for pain control, and then told to go to a dentist.
Yeah.
And these non-traumatic visits were all preventable. And that's the key. If these patients would have had regular preventive care and their oral health literacy would have been higher to know to brush and floss and use fluoride toothpaste and limit your snacks and so forth, right? All the things that we want to educate people with, it was all preventable. But it cost the state $52 million.
Hi, I'm Deanna Kepka from University of Utah and Hudson Cancer Institute. Along that lines around prevention and primary care and dental practices, I'm an HPV vaccine researcher.
Yes.
Don't we have an opportunity to be coordinating, especially at community health centers like family health care, between the dental side and the primary care side, to educate about vaccines and get folks vaccinated, you know, same day that they have their dental visits? I don't know how many community health center practices we have in the dental arena across the state of Utah, but it seems like this is the optimal place to be working together on the primary care side, the dental side.
Well, and that idea has been brought up before, right?
Yeah, I know, we've been talking about this for years.
I mean, who
Yeah.
who is the provider who sees patients the most?
I mean, I know you're thinking primary health care.
No, I'm
I
thinking
mean, the dental, all the
It
twice.
is.
dental hygienist.
Yeah.
Yep.
It's the dental hygienist who sees these patients. At
Yep.
least once a year, who have, well, let's clarify, who has insurance. Right?
Yeah.
And even people who have insurance aren't using their insurance. Even people who are on Medicaid, their children are on Medicaid that have dental benefits aren't necessarily taking insurance. So it's a lot of education. You're right, we need to, we were asking as hygienists, why aren't you using us to help give the vaccine, the COVID vaccine? Help us help, let us help.
Right,
patients.
and in Oregon, that's happening.
Yes, in Oregon, it did start happening. In Connecticut, they were allowing hygienists to help out. Yep. Great thing to bring up. Okay. I'll write that to you guys.
No, we really appreciate the research you're bringing to us. That's fascinating. Other questions?
Kind of along those lines, like, how do you feel like your role will expand now that if you guys can provide the COVID-19 vaccine, like maybe in the future you guys would be able to, you know, vaccinate for other things like flu, HPV. So how do you feel like it'll look?
That's a good question. Well, we're,
You
because
stumped them.
we're part of the, I mean, we're in the same building as like the medical clinic, so we have meetings all the time, and we discuss things like this that, you know, I think we help out, or how can they help, you know, educate, get people, that's something they've been doing a lot, is just patients that come in for medical issues, we say, we have a dental clinic here, if you want to get appointment with us.
Do you
So just
share
come.
electronic health records across, like when you have your patient come in, can you see their records with their family members?
We can, well, we can see like their medical history and stuff like that,
Okay.
so all that's kind of connected, but usually we don't kind of go into their medical records necessarily. But we do.
Just for
use
those
it.
preventive medicine type recommendations.
Yeah,
I do agree, like having a patient in the chair twice a year is an opportunity to educate.
So if you had a patient in your chair and
Yeah.
and they were a patient on the medical side, when you pop up the record, immunization needed, would you then educate that patient to go make that appointment?
yeah, and we do see,
You do
we
do
do
that.
see that.
So-
If
so-
we see something, we can be like, all right, so we do this, I mean, and we have the same schedule, so we can put them on the schedule for the medical side, so it works pretty
You should
well.
write a paper about that. That's more.
There's actually a
They're professional.
there's a clinic in Texas. There's a very similar setup where medical and dental together, and they did a project with increasing their HPV vaccines just pre-pandemic, where kids would be going in for their regular visits at the dental, and they would pop it up and it would say you're due for your HPV vaccine. They would send them right over. They would say, you know what, when you leave your state, you're going to go get your HPV vaccine, or it's helping to complete the series as well. So
Kind of working together, kind of.
yeah, and it was just, and they have a state protocol, so like, for the second dose, they don't have to see a physician, they can just get it from a nurse. And so it was just open, walking hours, and so we were able to do that.
There's some QHCs in Colorado who don't have a dental clinic connected, but they do have a dental in the pediatric base. They do have dental hygienists in them because the Colorado scope of practice allows them to do that. So in Utah, we cannot, but they're in there. And so if you go in, you take your child for a well visit, you can go right over to the hygienist to get their teeth cleaned, take some x-rays, do a fluoride treatment, see if there's any leaks, and see if there's a referral for that. So there's opportunities that are really great to model. Yeah, they started it probably about 10 years ago, and it's been very successful.
What would change that in other states? I'm just curious because we work in 5 states.
Legislature.
Okay.
Yeah.
Oh, fun.
Hey, finding an
How are you?
advocate. Finding a legislative advocate. Big things. So I'm curious, moving forward, how do you see education for dental professionals changing? Other than, learning?
Well, I'll take it. I'd like to answer that because I'm going through a Commission on Dental Accreditation site visit coming up. And
When's yours?
yeah, CODA, interprofessional is one of the big buzzwords in dental education. And we are working on, I think all programs are, to bring in, and it's not just in a classroom, it has to be actually with dental students, nurse practitioners, others in primary care work together before they even treat a patient. They're working together to decide if this is the best care for the patient. And for Diana, what she said about the HPV, do they need their vaccines? Diana, I've got a student that's going to reach out to you on Monday, just so you know about that. But it's a big, and we're working on it here. We have Interprofessionalism Day where they actually have simulated cases. We have pharmacy students, nursing students, and dental students work together. But I think eventually it's going to be similar to what some of the schools back east have done, Harvard, and I think it's Northeastern. I know NYU, the College of Nursing, is actually within the College of Dentistry, and they use nurse practitioner residents on the teams with the dental students to teach them how to properly assess the patient. And I think that's where we're headed. I think the Department of Education, along with Health and Human Services on the federal side, is pushing that. And that's our responsibility to make sure that occurs. There's no turning back from it. We're not going back to dentistry just standalone. It is interprofessional, person-centered care. Dave Sackett from Canada, the epidemiologist, was famous for writing about how important that was. And he fell on deaf ears back in '95 when he talked about it, but now people are starting to find him. It's too late. He died 6 years ago. But I think that's where we're headed is, and it does come down to the schools. It really does. It comes down to all of us to work together to train, especially our national health scholars. We have several, as Rita knows, at our program. And my background in the military, it works. I mean, a better patient, we deliver better care when we work as a team, no question about it. But we're working on it from this end. I think it will occur. I just don't know how fast, but I don't see us turning back from it. And we're always looking here for opportunities to work. We just found out our nurse practitioner program was just approved. And so that's a big step. Just 10 minutes ago, we just got notified, Brian Oxhorn, our Dean of Nursing, just let all of us know that it's been approved. And I'd like to think we'll probably work with the residents to try to, evaluate patients together at some point so that our dental students are comfortable asking the right questions. A lot of this, especially in interprofessionalism, what I found in the hospital is being the dentist. And when I had red hair, I was known as the redheaded stepchild of the hospital, was that a lot of it is, I know, it's about breaking down language barriers, the acronyms that the medical side uses versus what the dental side, and people understanding that it's okay to ask. I used to tell the residents, it's okay to ask questions. It's okay to reach out. They don't understand dentistry. You don't understand medicine. Let's work together to figure it out. And it takes a little bit of I don't know, coaching, if you will. They can do it. The GPRs and the AGD residents were able to do that. And it's a very successful model. And that's got to start sooner, though, than it did when I was at Balboa Naval and Bethesda. It needs to start a lot sooner. And it starts with us, and that starts with our interprofessionalness of events, because that's where healthcare is headed, the best healthcare. And as I said it earlier, primary care includes dental hygiene. Brenda teaches what Ryan's doing, the community healthcare clinic, one of our federally qualified health clinics, I'm sure. And it's that collaboration, and it starts with us in dentistry. And we're working on it. I don't know all the schools are looking for opportunities. That's one of the reasons I want our students to go to Ryan's clinic or a clinic like his to work in a setting like that, especially in a rural area, because I think they need to see that the access to primary care and the understanding of how important it is very lacking in a lot of the areas like Helper and some others. And it's important they realize that they need to be part of the solution, not of that problem in the United States. But we're working on it, and I don't know what it's like for the dental hygiene community, but you're right. You are the number one. More people see you than anybody else. All the data shows that. And to bring up vaccination issues, we had a lecture the other day for all the students on HPV. Mindy Bateman, if you know her, up at Crossroads AHEC, has been working with us, and we talked about it. Is she here?
She's actually in the audience. And
All right, Mindy, shout out for you. And but we brought other students in, and it's one of those opportunities where they are actually sitting together asking the same questions, and it went really well. We'd like to do more of that, but engaged. But we do believe in that, and that's one of the things we're working on with our dental students is to review the health history and mention vaccination for their patients. The messaging on that, Mindy and I talked the other day at Murray High School about that, and I know her head's going up and down, but she's right. We did talk about that. That's something we're working on to teach students how to do that. But anyway, that's where we stand. But education is a big challenge. I mean, just getting the message. And, for us, it's our faculty too that come out of certain, like I did, when I graduated from dental school, it was all about the mouth. We were just focused on that, nothing else. That was the norm. And it is changing. So we'll see. I'm confident. So.
Improve over time. We've been talking about IPD and professional education for a good 10 years. Yeah. And I think we'll continue to improve as some of us old people retire and new people come in and they have students, we have what should happen. And we work with respiratory therapists, we work with physician's assistants, with DO students. We just in small settings trying to get that understanding, but we also need to allow people to work to the scope of their education. And we haven't really done that. We haven't allowed dental hygienists to work to the scope of where they have an education. So I
was just wondering, because I was in the telehealth breakout, but how does telehealth play into dental?
We haven't done a ton of telehealth because, you can only do so many things. We did do a lot of tooth access whenever we could get in that do something that way, but the medical side did a lot more of that than we were in our clinic.
There is some telehealth happening up on the Wasatch Front. There's a group called Smart Smiles where they send in hygienists into schools. Schools want them there. And then they have dentists on the other side who are able to talk to the patient if they need to from a screen. But a lot of it is asynchronous. Sending the information to a dentist to evaluate after you've collected it too.
Any other questions for our panelists? Well, we certainly want to thank them for